Hello and welcome to our presentation entitled Themes of Recovery from a Child and Adolescent Eating Disorder Unit, Staff Experiences. Once we had articulated our aims for the study, we did a pragmatic rather than an in-depth literature search to answer the question, how have eating disorder patients and unit staff been affected by the COVID-19 pandemic? As part of a literature search, we found a very useful systematic review that examined the impact of the COVID-19 pandemic on eating disorders and eating disordered behaviours. This systematic review reviewed studies including individuals with or without a diagnosed eating disorder or disordered eating behaviours, and those that as well were exposed to the COVID-19 pandemic. It was a large review of 72 worldwide studies, of which half, in total 36, were from North America and Europe. So these were potentially generalisable to the UK population. We further assessed the similarity to our patient group of these studies, and we found that 10 studies used children and adolescents as their population. 5 studies examined eating disorder presentations in hospital or inpatient facilities, which was relevant to our research. These studies found that the pandemic was associated with more visits from young people requiring acute medical intervention. 4 studies assessed eating disorder behaviours, with most finding no significant differences in disordered eating scores pre- and post-pandemic. 1 study was qualitative in design and highlighted main themes associated with the COVID-19 pandemic in adolescent patients with anorexia. Some of these themes were restriction of personal freedom, interruption of treatment routine, changes in eating disorder symptoms, and opportunity for COVID-19. Our intentions for this study were to use a pragmatic but sound methodological approach to our qualitative research, ensuring we balanced a participant versus researcher perspective and captured a balance of both description of staff experience with inference to provide a foundation for a model for the recovery of a unit. Due to existing limitations of our setting, such as difficulties of accessing staff, a small sample group, and time limitations, our research was reflexive and pragmatic to fit with a hospital setting, staff, participants and audience, and to have outcomes that would lead to meaningful action. As a result, we chose to use an exploratory descriptive qualitative method of research. And we used mixed data collection methods in the form of questionnaires utilising free text boxes and Likert scales and staff interviews. A purposeful sample was chosen of staff members from our ED ward to choose a variety of represented disciplines and voices. Our MDT, or team, includes support workers, nurses, nurse associates, dietitians, teachers, therapists, and trainee psychologists. We used a simple coding process where core concepts and theories emerged from data analysis, and we used constant comparison. We overall took a pragmatic approach to the grounded theory method of data analysis to respect the limitations of our study and our chosen topic, which has no definitive previous research. After analysing the data from the questionnaire, we looked at the emerging themes. Question 1, which focused on the impact on staff at work, highlighted the emotional distress and social isolation that COVID brought. In addition, lockdown triggered illness and worsening of eating disorder symptoms, and it also brought more short staffing. From question 2, which focused on the impact on patients and service delivery, new protocols for patients were delivered, and there were feelings of claustrophobia from reduced visits and outings. Question 3, which focused on adaptation and differences in working practices during the pandemic, brought out themes of PPE, which have become the new normal, as well as ongoing staff testing.
Our numerical data shows a moderately strong correlation between the perceived impact of COVID-19 on staff's work and the length of time that they have worked within the service, meaning the longer staff have been working on the unit, the greater the perceived impact of the pandemic on their work. Our results show a relatively weak correlation between the length of time which the respondents have worked within our service and the perceived degree of change and job adaptation as a result of the pandemic. This might be attributed to the amount of new staff who have been working with our young people since the pandemic began, who do not have sufficient reference points to compare the service to a time before COVID-19. So knowing what we know from questionnaire 1, we started to evolve our study and created questionnaire 2. With the first questionnaire, the process we used was to move backwards and forwards between data analysis and data collection in order to make comparisons and form initial categories and concepts. From this initial data, it was evident that staff struggled to express ways they've adapted their working, as they have accepted that COVID-19 is a permanent part of their job role, and they wanted to focus on recovery in their answers. Questionnaire 2 was then developed in order to collect more focused data, specifically to collect and explore data relating to recovery. So, we went back to the literature and asked ourselves, what does recovery look like? The following review carried out a literature search for recommendations and guidelines worldwide, either in English or in German, that focused on support for healthcare workers during the COVID-19 pandemic. All articles included were published between April 2020 and May 2021. 41 publications were analysed in total. So this is an overview of the types of recommendations given to improve mental health in healthcare workers during the COVID-19 pandemic. The numbers of publications, including each recommendation, are displayed. The dotted line displays the threshold of referencing the given topic in more than 50% of the included publications. The scoping review could identify 4 main categories of guidelines and recommendations to improve mental burden in healthcare workers during the pandemic, namely social or structural support, work environment, communication and information, and mental health support. So in summary, 11 articles stressed the importance of validation and acknowledgement, but remained vague about specific strategies to actively show appreciation and validation for staff. 16 articles emphasised the need to listen to staff input and feedback. Leaders should provide the opportunity to talk to them and implement regular feedback mechanisms. 19 articles recommended to implement staff retention, for example, ensuring adequate compensation, rotating staff, or mixing skills. 5 articles recommended providing psychological care and monitoring staff who are at higher risk of developing a mental disorder after the pandemic begins to recede. Most articles only focus on the time of the acute crisis and neglect what might happen when the crisis is over. They neglect the potentially ongoing stress and burden healthcare workers might face after the pandemic, for example, postponed treatments, structural changes in the healthcare system, and staff shortage. One of the articles in the review described the 4 key elements in an evidence-based staff National Health Service recovery plan, and this has been developed based on the NICE guidelines for PTSD management. This includes written and verbal thank yous, which acknowledges staff's work, return to work interviews conducted by staff confident in discussing mental health issues, active monitoring for anyone exposed to trauma, and group discussions to develop a meaningful narrative. Of all of the articles included in the scoping review, no articles at all included those working in psychiatry as their healthcare workers. We want to represent our specialty. We want to see how our staff are affected, as these articles mainly look at general medical staff, and this is a generalised overview of how staff are affected. Now is the time to act to promote recovery with our staff. Multiple studies worldwide point to a relationship between a crisis and a then lagged adverse impact on population mental health, including suicidal behaviour. As vaccination programmes continue and infection rates fall, pressure will increase to reduce public expenditure. Historically, mental health services have been very vulnerable when public funding is constrained. After the 2008-2009 financial crisis, mental health systems in some European countries experienced grave budget cuts. This is a critical message. Even when the pandemic is fully contained, there will be additional future demands on mental health services. As we start to move out of the pandemic, now is the time to plan for long-term recovery and to anticipate that lagged effect on our population's mental health.
In response to the scarcity of the literature on the pandemic's effect on staff outside of general medical staff, we developed a second questionnaire. This questionnaire would focus on 2 key aspects of the pandemic's impact on our eating disorder service. The first question of our questionnaire explored the perceived degree and specific ways in which our eating disorder service has begun to recover from the difficulties that staff will have faced during the pandemic. And the second explored ways in which staff and patients could further be helped by the hospital in this recovery period. This table shows an example of the simplified coding process. The core concept that is being expanded upon in this table is the reduction in anxiety surrounding coronavirus, leading to improvements in staff well-being. We extracted some of the raw text from our participants' answers and linked them to one of our overarching themes. In this case, the overarching theme of infection anxiety was characterized by these quotes. Expanding on this theme of infection anxiety, it was possible, from the participants' responses, to identify that anxieties linked to infection were proportionately lowered the more COVID was perceived to be understood. The vaccine and the prospect of having protection from the virus at work played a significant role in feelings of safety and staff members' ability to stay focused. As well as the impact of the vaccine and an increased understanding of the coronavirus on infection anxieties, the overall impact of COVID-19 on staff's mental health is reported to have reduced. This improvement can be linked to the acknowledgement that in the initial lockdown phases, the panic culture that was inextricably attached to the pandemic is no longer as prominent. The relief of this type of pressure and moral stress of spreading COVID has played a significant role in the theme of infection anxiety. In this table, the core concept of the ability to resume the therapeutic model of reintegration with loved ones outside of the hospital and reduction in both voluntary and involuntary isolation was established. This core concept was built on the overarching theme of access to loved ones, a prominent theme which was further characterized by more quotes from participants identified from the pool of responses. Expanding on this theme of access to loved ones, it was clear from the responses that reconnection with family and friends was the foundation upon which more opportunities to rebuild normal life began to develop, where patients were able to see further ahead into their recovery, looking forward to more opportunities for social contact with people they were otherwise unable to see because of lockdown restrictions. Time outside of the hospital is a critical component of recovery, giving the young people the ability to practically manage the world and its people, both inside and outside of their home. Family support is a cornerstone of recovery within eating disorder services, and nowhere could that be more true than within the Tier 4 inpatient setting. Being able to see family in a more structured and flexible way has meant that patients are no longer isolated from recovery, either self-imposed or as a result of COVID-19 precautions. Again, the responses were collated and a core concept from these answers was identified. In this case, the core concept of how to better help both staff and patients through this recovery phase of the pandemic was the ongoing promotion and implementation of personal protective equipment, as well as prophylactic COVID testing regardless of government recommendations. This core concept housed the overarching theme of ongoing precautions and was characterized by quotes from the participants. The quotes represent the consensus among the participants that the use of PPE and the continued LFT tests before you come to work should continue. It also emphasizes the need to remember the impact that COVID has had on our eating disorder service and not to develop a false sense of security by remaining connected to the relevant health education linked to the risks of COVID-19. Despite the inconvenience and frustrations that precautions like PPE and LFTs might bring, it is still important to keep stock of them, because although we as staff members might be safer from infection now, the patients within our eating disorder services are still vulnerable. The final core concept drawn from the pool of responses was the need for clear evidence from the hospital's management of real recognition of the staff's efforts in the pandemic and validation of the staff's feelings. This type of acknowledgement will contribute as a necessary support and foster a culture within the institution which promotes recovery. The overarching theme of acknowledgement is informed by quotes from the staff. It is widely agreed within the response pool that seeing managers on the shop floor makes a difference, and the acknowledging that we are all in this together is an invaluable form of support that staff are asking for. Seeing management and hearing their support is but a part of the acknowledgement theme. Staff have also expressed the need for tangible forms of thanks and understanding of what staff have been through over the course of this pandemic. More personal communications of thanks is needed to match the degree to which staff have exceeded their normal job responsibilities during the numerous lockdowns and the imposed restrictions that came from the pandemic. In addition to the core themes that were already mentioned, other significant observations made by staff tied into themes of morale, that there should be more staff morale strategies and that patients would respond best to a motivated team, family therapy, and the increased need for more access to it, especially since family life has been so different over the last 2 years, and support culture, that patients have shown a lot more cohesion and resilience than expected because they've had to work together in an unprecedented way. This kind of internal support has affected the support culture on the ward and hasn't just disappeared because the pandemic is over. At this point, we use a comparative analysis to look at our previous sampling, data collection, and analysis. We used methods from exploratory, descriptive, qualitative sampling and theoretical sampling to purposefully recruit participants based on their different experiences of a shared phenomenon, in this case, the COVID-19 pandemic. Our questions at this point were, where do we go next? Who are the staff group that can most inform us on the important themes identified? Our participants were selected for this based on their specific characteristics. A very experienced senior support worker who is undergoing higher training in psychology and counseling, a senior occupational therapist who plans and implements outings and local leaves, and a member of the senior management team who overall manages nursing and support worker staff and has the ability to implement real change. Their perspectives on recovery on our unit are highly valuable, and here are some extracts from the first 2 interviews.
I think, home leaves, local leaves have such an impact on them, and it's goal setting. So these are the goals they're working towards, and when you're in lockdown, what are you actually working towards? What incentive do you get? It's very, very difficult, and on top of that, you've got anxiety of the unknown, and how do you deal with that, because no one knows. Staff don't have the answers. We can't, they couldn't see their their families. So, coming away from all of that, I certainly think there's, hope, and, the light that they need at the end of the tunnel, and, the goals they've been, working towards, whether it be school or part-time job or, the future. When the country's in lockdown, schools closed, most workplaces are closed. So, what are these patients working towards? I certainly think now, a lot of people are in a different place, and hopefully these goals are in sight now. So I certainly think that's helping with the recovery. Introducing more local leaves with staff would be beneficial both to staff and to patients. Going for snack outs, giving them the freedom and the choice, and that the choices they can make for themselves. It's like a transition into the community. It's certainly beneficial, and I think that would help a lot. And also, staff meetings and focusing on staff well-being. So maybe looking at mindfulness for staff, and having or getting ideas from staff what their needs are, because it has been a long stretch and it has been a difficult one, and it has, like I've mentioned before, a lot of anxiety for staff, trying to keep these young people safe, trying to keep their families safe, trying to keep themselves safe at the same time.
One of the key difficulties that I observed during the pandemic were the consequences of limited access to the community for our service users. As an OT, one of my key roles is supporting our young people to re-engage with life in the community in a way that is meaningful to them. Eating disorders are incredibly world limiting, so supporting young people to explore life in the outside world is really crucial to helping them forge an identity beyond the all-consuming identity of an ED patient. It has been really good to see the impact of the world opening back up on our young people and the staff alike. We can now more easily do the work that supports transition from hospital to the community. Outings are now regular occurrences, with snack out and recreational outings being offered weekly. Crucially, as therapists, we can do the graded exposure work individual patients may require in order to access the community. I think it would be helpful for there to be more reflective spaces offered for both staff and patients together, especially when working through something as complex as a pandemic, which is very much so a shared experience by all. At present, we have process group for the young people to explore their issues, and we have our individual reflective practices within our groups. But I think it might be helpful if both staff and patients could join up on this. For context, Process Group is a weekly space for both staff as well as patients to be heard in their own respective groups. Psychotherapists and clinical psychologists run these groups for the patients and staff. These groups provide a safe space for patients to raise issues or concerns that they might have about sensitive topics or themes, either anonymously or not. Having conducted the interviews and comparing their data to the data we received from our questionnaires, we can see that this was the most common answer: outings, local leave and home leave. An overwhelmingly significant theme in our unit's recovery is the ability for patients to engage in this leave. This is their goal and an important part of the treatment model to allow patients to challenge their anorexic behaviours outside of the care and support of the hospital. We now move on to the interview with management. We asked them the following questions focused on recovery and resilience. During the COVID-19 pandemic, were any acute measures put in place to help support staff? Going forwards, what do you think are the next steps for supporting staff well-being? They made an astute observation. There is a double burnout risk with staff here at our unit. 50% of the stress is related to the pandemic, 50% is related to being a Tier 4 unit. It is management's view that we are very much still recovering from the COVID-19 pandemic. Looking back to the early days of the pandemic, management noticed several observations. They noticed a change in ward acuity with an increase in the amount of patients requiring nasogastric feedings and increased levels of staff observation of patients since the start of the pandemic, as well as changing patient psychopathology with a higher amount of patients presenting with emerging emotionally unstable personality disorder. These presentations cause difficulty in discharging back to the community due to the level of risky behaviour patients engage in. There is a lack of a clear discharge pathway with these patients and a lack of Tier 4 beds to transfer patients to more appropriate wards for treatment. The acute measures that were put in place at the beginning of the pandemic were the introduction of remote working, especially for therapists, to ensure the vital work of therapists could continue despite isolation, COVID-19 infection and shielding. There was clear communication of COVID processes to staff and families, including guidelines on PPE, lateral flow testing and visits. A weekly drop-in session with management was introduced, as well as a clear open door policy to support staff and allow them to comfortably communicate with their management team. Management have a long-term plan for supporting staff and our service following reviews and reflections peri and post-pandemic. This includes the introduction of hybrid working, flexible shifts to ensure staff have time off the ward to reduce fatigue and burnout and enhance staff retention. This will involve early and twilight shifts. Investment in immersive technology and improving communication tools. Technology will be used to set up a model bedroom on the ward so incoming patients and their parents will be able to see the environment where their child will be staying. This was a real source of anxiety for parents during the pandemic. Daily debriefs specifically for key working sessions. The one-to-one sessions with patients and their key worker, so nurses and support workers, are a vital form of support. These debriefs will help staff to explore and manage any increased and challenging ED behaviours which we have been seeing in the pandemic. The proposal of specialised ED PICU beds to provide NG feedings and face-to-face pre-assessments with patients before being admitted to the ward, along with ED specialised support worker roles to develop programmes for support workers, team away days to help boost staff morale, and ongoing COVID precaution measures. Management hold the view that COVID precautions are still essential, and rather than listen to any future government announcement or guidance that we can reduce our levels of PPE and COVID-19 testing, our management would prefer to carry on with this to keep our staff and physically vulnerable patients safe. Also, a new model for family therapy has been produced. So, what else have we done to support? We have looked at the value of animal companionship in the pandemic. Animals have proved to be providers of social and emotional support, and providers of purpose and perspective. Our new hamster continues to be a key feature of relief from the weight of the pandemic for both patients and staff, and has reopened the channels for animal-assisted therapy. So in summary, we have identified COVID-19's impact on our service, initial recovery in our service, and requirements for further recovery and rebuilding. One of the most noticeable areas of recovery has been the ability to resume the therapeutic model of reintegration with loved ones outside of hospital, and a reduction in voluntary and involuntary isolation. So snack outs, outings, home leave and local leave. This has been identified as one of the most important parts of recovery in our service. In terms of moving forwards, we feel that there are strong arguments for management's recovery plan for our unit, backed up by the literature and staff views in our data collection and analysis. These are actions that we support moving forwards that are eating disorder unit specific. Firstly, new roles. The development of eating disorder specialist support workers to support staff in dealing with the increased ED symptoms seen on the ward. Staff have recognised a big impact on their working and difficulties in seeing patients suffering with increased ED symptoms. Our staff have noticed this, and this is also in the literature. So supporting staff in dealing with eating disorder behaviours and related deliberate self-harm is vital. Family therapy, an extremely important part of the treatment model for anorexia nervosa. There have been national shortages of family therapists. A new model has been developed to incorporate hybrid working and utilisation of technology. So management have proposed a mixture of remote therapists and therapists on site. If there are further restrictions and government-mandated isolations, this protects against staff loss. This also allows family therapy to continue in patients that refuse virtual therapy. PICU beds. The development of specialised eating disorder PICU beds to ensure staff on our ward are not overrun with the need for NG feedings and ensure patients receive the high levels of observation and risk management they need in the appropriate setting. And face-to-face pre-assessments. This has been developed to think about the mix of patients, symptomatology, risk, and how this would affect ward acuity and pre-existing patient recovery. Alongside management's plan for long-term recovery in our units, we propose an additional, more generalised action plan for recovery. We aim to create an action plan that has an evidence base either within the literature or our staff questionnaires and interviews. This includes flexible shifts, twilight and earlies which help with staff retention and reduce the risk of burnout, team away days with a clear focus on appreciation from the senior management team to give evidence that they understand the experience staff on the shop floor have faced during the pandemic. Ongoing COVID precautions, so lateral flow testing and adequate PPE regardless of changing government guidance or easing of regulations. The formation of a staff wellbeing committee made up of representatives from each of the disciplines, doctors, nurses, support workers, dietitians and therapists, which will meet with senior management monthly to discuss strategies to improve wellbeing and report any concerns representatives have regarding the mental health of their team members. This engages in active monitoring of potential staff exposed to trauma, which is the majority of healthcare workers in the pandemic. The implementation of a regular debriefing session in which staff are able to discuss traumatic events, which does not need to be limited to events surrounding COVID-19, and be debriefed by a trained professional utilising brief psychological interventions to start the processing and healing from the pandemic. Further reflective opportunities for staff and patients, alongside joint activities for patients and staff to do together, for example summer fetes, charity fundraisers and games. The limitations of our study are as follows. It's a small study with a small cohort of staff to gather responses from. We are one 20-bed unit, and engagement with the questionnaire was difficult to promote when staff are so busy. Agency or new staff had not experienced the pandemic at Huntercombe, so they could not judge the level of recovery. Staff struggled to express ways they have been impacted by and adapted their working as a result of COVID-19, as there is an acceptance that this is a permanent part of their job role. Support workers have the highest numbers in our MDT, so our main participants potentially missed themes identified later in theoretical sampling. Some major impacts or needs for recovery were not initially picked up, as support workers wouldn't have seen evidence of this or it wouldn't have affected them. Here are some closing remarks from our consultant, Dr. Mark Tattersall, consultant psychiatrist and eating disorder specialist.
I think we're just at the start, even though it's been quite a long time with the pandemic, we're at the start of really using the improvements in technology and changing working practices to find a way of optimising that. So this ought to have a positive impact on the ability to work more flexibly with families in family therapy, but also in parent support groups, and in general working more closely with community teams, families and schools and the whole wider network.